A 62-year-old woman with type 2 diabetes, well controlled on glibenclamide 5 mg daily, developed symptoms of a urinary tract infection. Her local clinic prescribes ciprofloxacin 500 mg twice a day. Just 12 hours later, her family notices she is sweating, dizzy, and unable to speak clearly. At the ER, her blood sugar is found to be 28 mg per deciliter. Further tests show very high insulin and C-peptide levels, confirming severe hypoglycemia due to excessive insulin release. When her medications are reviewed, the team immediately identifies the cause: the dangerous interaction between ciprofloxacin and a sulfonylurea. Some fluoroquinolones, especially gatifloxacin and to lesser extent levofloxacin and ciprofloxacin, can interact with the sulfonylureas, for example, glimepiride, glibenclamide, gliburide, leading to increased risk of hypoglycemia, especially in elderly peoples, those with kidney problems, or individuals with irregular eating habits. And some studies show that hypoglycemia from this interaction occurs mainly in patients aged 18 to 64. When we eat, our blood sugar begins to rise. As glucose levels increase outside the beta cells, glucose naturally flows into the beta cells, down its concentration gradient. It enters through a specific transporter, primarily GLUT1. This is a passive transport mechanism, so it doesn't require any energy. Once the glucose enters the beta cell, the cell needs to trap it. That's where glucokinase comes in. This enzyme immediately phosphorylates glucose to glucose 6-phosphate, and importantly, glucokinase acts as the cell's glucose sensor. Its activity rises linearly with blood glucose levels. So if glucokinase works slowly, insulin release will also be slow. From here, the cell begins metabolizing the glucose through glycolysis and then the Krebs cycle inside the mitochondria. As a result, there is a massive production of energy. Specifically, the ATP to ADP ratio increases sharply because much more ATP is being produced than ADP. Now pay close attention. On the beta cell membrane, we have ATP-sensitive potassium channels. Under resting conditions, these channels remain open, allowing potassium to leak out of the cell. As positive charges leave, the inside of the cell stays negatively charged. We call this a hyperpolarized state. But when we eat and ATP levels rise, that ATP binds to these potassium channels and closes them. Once the channel closes, potassium can no longer leave, so positive charge starts building up inside the cell. This causes the membrane potential to rise. It becomes less negative, and we call this depolarization. The beta cell also has voltage-gated calcium channels, and they are waiting for exactly this change in membrane potential. When the cell depolarizes, these channels open, allowing calcium to rush in from outside. The increase in intracellular calcium then triggers the cell's cytoskeleton to move insulin-containing granules toward the membrane. These granules fuse with the membrane and release insulin into the bloodstream through exocytosis. And that, in a nutshell, is the normal physiological process of insulin secretion. Now, in the same way sulfonylureas act, they bind to a specific receptor on the surface of the pancreatic beta cell, which is the part of the ATP-sensitive potassium channel, and directly block this channel. Even without the rise in ATP, the channel closes. Potassium can't leave, and the cell begins to depolarize. This depolarization then opens the voltage-gated calcium channels, allowing calcium to rush inside. And exactly like in the physiologic pathway, the rise in intracellular calcium releases the insulin into the bloodstream via exocytosis. Interestingly, some fluoroquinolones can also block these ATP-sensitive potassium channels. As a result, they too can stimulate insulin release. and in certain cases, this effect occurs independent of the blood glucose level. So when a fluoroquinolone is combined with a sulfonylurea, both are pushing the same mechanism toward increased insulin secretion. This additive effect can drive insulin release far beyond what is needed, leading to a sharp drop in blood glucose levels. Also, the fluoroquinolone can inhibit the cytochrome P450, specifically CYP2C9, which is responsible for metabolizing some sulfonylureas like glyburide. This inhibition slows down the breakdown of sulfonylureas drug, thus also increasing the risk of hypoglycemia. The main risk of this drug interaction is severe hypoglycemia, and the symptoms include dizziness and confusion, sweating and tremor, rapid heartbeat, and in severe cases, loss of consciousness or seizures. Note: Gatifloxacin was withdrawn from systemic use in many countries due to dysglycemia risk, especially in diabetics. Because of this risk, patients taking both medications need close monitoring, including frequent blood sugar checks and possible sulfonylurea dose adjustments. They should also be educated about the signs and symptoms of hypoglycemia.